for including me in this session. So I'll be talking about managing severe dry eye, a very tricky affair, no financial interest. So the first tricky part is there is no uniform definition as per the DUS2 classification. You can have severity based on clinical grading, imaging, investigations, questionnaires, and also subjective grading. This is something from the Mexican group of dry eyes. So they have given it based on the symptoms, questionnaires, clinically what you're seeing on the breakup times, staining, the Oxford's grading system, Sharma's, and also looking at the lids and the restoration of the ocular surface. This is something you can go by to determine what is severe. And the first thing begins with severe dry eye is patient counseling and motivation. So these are patients who have already roamed around multiple doctors, switched multiple medications, and they want quick relief. So you have to explain the chronicity, explain the costs, explain control versus cure, motivate lifestyle changes, and in some extreme situations might warrant professional changes too. So just an outline of the management, it requires multimodal approach. So this is from a survey that was done in the US. So if you look at the severe dry eye, 4 to 5 and above grades of modalities, the last row if you look. So in severe dry eye, more than 50% requires more than 4 or 5 different modalities going on to treat them. So there's different groups of pharmacotherapy, oral medications, procedures, devices, compounded medications, and finally surgical interventions. And this is again very familiar from the DUS2 classification. So here we are looking at the bottom part of the chart. So briefly speaking, you start with the lubricants. You have to start with something higher lubricants. Start with something with high retention like hyaluronate or HP guar. Osmoprotectants definitely have a role. We have now lipid-containing drops in our country. Again, electrolyte-containing drops are required to replenish whatever is lost. However, the ideal artificial tear drops to treat severe dry eye does not exist in market. So here is the role of topical immunosuppression. So mostly we usually start with the initial short course of steroids. However, in very severe situations, you might require them to be given over a prolonged period of time. All steroids have been studied and you can give them choose as per depending on the severity. Now comes the role of immunomodulation. The previous speakers have covered it quite well. Cyclosporin A is the most commonly given eye drop in this category for severe dry eyes. We have newer formulations like the cationic emulsions, which are equally effective as the initial molecule. And there have been some studies which have experimented with 3 or 4 time dosing instead of the BD dosing. Tacrolimus can be given. The lifitegrast has shown good efficacy, but we are sort of debatable about the shelf life of the medication. Next, punctal occlusion can be done with the plugs, which can be either temporary or permanent, or you can go ahead with the surgical approach by either a cautery, radiofrequency knives, or even suturing the puncture shunt. Procedure based, the MGD treatment procedures are quite well established over the almost 10 years now. We have the thermal pulsation therapy and the intense pulse light also. Now that it has FDA approval, we can expect to see much more publications. There is this nasal stimulation device. You just put it in your nose, it delivers a short electric current, and hopefully that stimulates the lacrimal glands. And then there is definite role of scleral and specialty contact lenses. Autologous serum drops, they work amazingly well in severe dry eye due to the anti-inflammatory and epithelial growth properties. However, there are logistic limitations. So now what people are doing is they're experimenting with direct autologous blood. So you ask the patient to do finger pricks 4 times a day and then they apply the same blood in the eyes. If you don't want to do that, there is the allogenic serum drops. This has been extensively studied in the GVD, chronic GVDH patients, and also there is interest in the umbilical cord blood serum. However, no superiority studies have been established. Now we have this is a new hype, the platelet-rich plasma. You can make drops containing platelet-rich plasma, or you can inject directly into the lacrimal glands, which have shown promising results. I guess this would be the newer research which is yet to come. Surgical approach, tarsorrhaphy. Already Dr. Nerd has explained how tarsorrhaphy helps. This is again a very promising thing which is slowly being uptaken. It's more in the domain of the oculoblast researches, the salivary gland transplants. And in cases severe dry eye, we can have sterile melts. So this is urgent surgery in the form of either corneal patch, glue BCL, a Tenon patch, maybe combined with tarsorrhaphy, and maybe even a keratoplasty in extreme situations. Amniotic membrane, again, if the surface is breaking down too frequently and too bad, amniotic membrane definitely can rescue that. It has got anti-inflammatory and growth properties. And then these are the oral and non-ocular medications. So oral secretagogue pilocarpine definitely has been studied. This is something available in the US. This again is a nasal spray which promotes the tearing secretions. And the neuropathic pain has been studied to have some role of vitamin B12. So you can probably try and test them and give oral parenteral supplementations. So when I was looking at the PubMed, so the first publication on severe dry eye was back in '86. And there they were talking about applying vitamin A ointments. So word of caution here is because there are so many new publications and new medicines coming in, so you have to be really careful about choosing what you give to your patients. So this was the infamous publication or the research by Dr. Shekhar Singh, which eventually led to some scandals at Harvard and Mass Eye here. So finally, the tricks to managing severe dry eye. So you should have a knowledge of the various pharmacotherapy modalities. Definitely multimodal approach is needed here, so drops plus devices. Treat the underlying systemic cause, and you should time the surgical or any other procedure-based interventions correctly. Thank you very much.
Thank you so much for an excellent talk. And yes, you must bring frequently in the halls also. It will make us stay awake also. And I think you managed the topic very well in 6 minutes. Covered a lot.